the wall is one of the best teams any federal agency could ever have, and that's a team of individuals who works explicitly on rural health issues at the Health Resources and Services Administration. So they are familiar to some of you. Others of you may not have met them before today. Please do introduce yourselves before you leave. They are just unbelievably passionate about health care, and specifically as it affects our rural health issues. In addition, it's the Deputy Administrator, Dr. Marsha Brand, Deputy Administrator for the Health Resources and Services Administration, actually lives in West Virginia. Many of them are from rural areas, actually, originally from different states across the country. So thank you for all of the work that you've done in preparation for this meeting, and thanks for the opportunity to introduce them.
Great. Well, I'm going to kick it off here and just throw out a question. I'm going to call on the Dinsdales because I already talked to them about my fishing trip to Montana this summer. I don't know if I'm going to get to do that or not, Congressman. Sounds like we're going to be busy. But I'm going to ask them to talk for a minute about what they see in Montana in terms of accessibility and costs of health care.
Well, I certainly thank you for this opportunity. I guess we've had the ultimate in lifestyle, as you mentioned. We got to live the dream, and our health care, I don't know if we could actually say if we suffered. We never had a death in our family. That's the ultimate of health care, I guess. Maybe we were lucky. We didn't have access to what is known by perhaps urban, and I'm talking on school here. I don't understand what urban access to health care is. But we didn't have that type. Of course, we'd love to have similar health care to what the rest of the world does, the rest of the country does. I don't know if we would be excited about trading our way of life for health care if it's that extreme. I hope we wouldn't have to.
Do you have coverage now? Do you have health insurance now?
I've turned 65.
So you're Medicare?
Yeah, I'm on Medicare.
Jody, what about you?
I have health care. I have such a high deductible to afford my health care that I not only pay my insurance premiums, but I usually pay all my expenses alongside. So that's a big concern for me.
And you have a farm? Is that how you all make a living?
We
Right
have
now.
a ranch.
So did you purchase your health care on your own, or what did?
On my own.
Are we ready to trade our way of life for health care, or are we asking for something short of that?
Well, I don't think anybody's talking about trading our way of life. No, we're just talking about what are the costs that you're facing. You know, how many rural people have insurance versus those in urban areas, which we find there are much higher rates of uninsurance in rural areas. So it sounds like you're two people who have been fortunate. Were you able to have coverage before you were eligible for Medicare, or not?
At perhaps less than a quarter of the time. And at that, I guess I would consider that an extravagance, as we saw the needs in our lives. Although the catastrophic situations that happened in our process, in our lives, were taken care of by rural doctors, by rural providers, that even the hospitals that don't exist today. These folks were such fantastic people that they saw that their kids stayed alive. The rattlesnake bite was taken care of. And all of a sudden, we came in and they said, pay it when you can. You can pay $50 now.
That's what Mary was talking about.
You know, is that day gone? I hope not, you know. Although it wouldn't be accessible today, we couldn't go to the same spot and say, doctors, what can you do for us? They'd say, they do say, what do you have for coverage? And if we were required to furnish ourselves first dollar coverage, it would be a life change. We couldn't live our dream. And
I was looking, Alan, do you have something to add from your?
First of all, I really appreciate you holding this meeting. Thank you very much. I know you're from Chicago, but we're all rural at heart, so that's okay. We'll take you. Ted, right to your point, my father is a barber in Holton, Kansas. That's 1.5 stoplights, Congressman. We're a little bit behind you on that. But it was a wonderful day yesterday. He turned 65. And my father is recovering from colon cancer, and he put off getting his port removed until this week so Medicare can cover it. That's the situation that he's facing there in a rural community. He's Blue Cross Blue Shield, town barber, self-insured. When you're talking about rural America, you're talking about people that are either self-insured, no insurance, underinsured. The access issue is critical on this. And I greatly appreciate bringing everyone together. I greatly appreciate the focus. The main message I was hopeful to convey, Dr. Wakefield hit it right on the mark, and that is rural is a great place for innovation. And I certainly hope that the message that's conveyed to President Obama and to Congress is that rural is not left out in this process. There is a great opportunity to try innovative approaches in rural America. And I hope that we have some demonstration projects. A lot of the discussion is how do we exempt rural. Let's put it at the front. Let's have rural lead going.
What's an example of that?
Well, I think we've seen some creative examples of health insurance co-op pools in some rural areas and how that works. I think in rural areas, some communities, you have good collaboration between critical access hospitals, rural health clinics, community health centers, and collaboration makes the difference. I think that if we can use some creative demonstration projects of collaboration among rural provider types, we ought to be able to carry that over to address the continuity of care that we're so desperately seeking as a nation as a whole. That's one example. Another thing that, and I want to make sure I hear from everyone, but I do want to address the issue the Congressman made about access to care over providers. You've got to make sure that the pay, as a former administrator of the Healthcare Financing Administration, you know personally how fragile the rural system is. And you've got to make sure that the payment levels are adequate to keep that access out there. I'm from Holton, Kansas. I work here in Washington, D.C. I'm delighted to work with the administration as this moves forward. But I can't wait to move back to Holton. That's because I'm a rural kid. And in education, if we can keep the rural kids in rural America, train them in rural residency tracks, that's going to help us out in the workforce. Really appreciate this.
Dennis, you...
Yeah, I'm honored also to be here and be part of this illustrious group, and it's a pleasure to talk with some of the folks that sit around the table.
And why don't you say where you're from, because everybody's...
I'm Denny Aaron. I'm the director of the Office of Rural Health for the state of Nebraska. I'm president-elect of the National Rural Health Association. I'm past president of the National State Organizations of Rural Health. And I've been very blessed for 19 years to have this wonderful opportunity to work with rural communities and rural health providers. I'll tag team with what Alan just said. I grew up on a family farm in Iowa. My brother still lives on that family farm, and there's no way that he can maintain his quality of life while he and his wife have to work off of the farm, basically for insurance. And because they were, I think about 10 years ago, they were paying $1,000 a month for insurance, and that was $2,500 deductible. My mother, who will turn 90, never had insurance until she had Medicare. It's pretty typical of rural communities. They depended on their neighbors, their friends. My dad broke his leg, and the neighbors came in and helped harvest and do whatever was necessary, and that's how it got done. We had a family doc in town who took chickens and quarter of beef or whatever it took in order to pay for that. I mean, it sounds quaint in effect to say that, but I think really what you're saying is there's a way of life that has turned on us. But I'm, like Alan, I'm also very optimistic of where we are today. We're at such a fascinating time in our history. If you think about the forces that have come together. And President Obama is wonderful in the way he, in effect, is capturing the connectivity of everything. So if you think about where we're at today, ecological integrity, social responsibility, and economic viability, that's really kind of his message. It's kind of what we're all struggling with. That's all taking place in rural areas. If we never have lost that, there are remnants of that runs through. That sense of community that's so important to actually all of us is there. What we got killed with was in fact the Industrial Revolution. The Industrial Revolution set in motion forces that we were incapable in small communities and on our individual farms, ranches, fisheries, or whatever, to compete with. And now we're into the information age, and we're beginning to rediscover the importance of food and all of the things related to food, as well as the sense of community. I mean, if there's one thing high-tech has done, it is causing us to re-examine communities and building relationships with one another. And that's all pieces of this puzzle that we have to put together. Before I came, I actually looked up the word reform. I don't know if any of you bother to do this because this is a health reform meeting. You know what the Webster definition of reform is? I'll read it to you because I wrote it down. To put an end to an evil by enforcing or introducing a better method or course of action.
And it is true reform. You're right.
It is true. So, I mean, there are so many things that we want to talk about, and I'm going to defer to the rest of you, but I mean, this is exciting time, and to be together with folks here who collectively we can make a phenomenal difference.
Armando, I know you're a farmer as well.
I am. We have in Colorado, Armando Valdez ranch, about 250 cow-calf operation, about 350 head of ewe lamb operation, sheep. And it seems like it's a trade-off. It's a trade-off to live in a rural area because you want the lifestyle, you want that way of life, but you have to trade off some of those valuable services such as healthcare, especially when you move back to a more rural area. You don't have any specialists. We have a very minimal amount of specialists in our area. We have a high turnover of physicians. So you don't have any of that continuity of care, especially when you have a primary care physician that's required as part of your plan. That doesn't continue over time. So that consistent coverage is one of my concerns that's out there. It's being able, the high expense, being an employer, we often get several propositions to offer health insurance for our employers, and they send us several different promotional materials on how this plan would work for them, this plan would work best for us, work best for our employees. And I started thinking how much money they put into those promotional materials that could be put into healthcare. And so I started doing some research, actually, and they're for-profit entities, and I'm a for-profit entity, and I am definitely not against them making a profit. They make about 10-15% in profit. The promotional materials actually double that. They're actually about 20% to 25% in promotional materials. And then I figured every time I call into my insurance company and they keep me on hold for about a half hour, there's probably got to be some administration expense there. I figured out of every dollar, there's probably 45 cents going them that's ever making it to the health. I mean, that's not even getting to my health before I ever get serviced. And so that makes me frustrated. And I know that's not just a rural issue, but that's something that I see directly in our area.
How many people work on your farm?
Well, it's seasonal, okay. So it definitely depends. And I can't provide insurance. I can't provide insurance.
Don't provide insurance, yeah.
So it's mainly more some contract labor, that's seasonal labor, mainly in the spring and the falls. When we're doing harvest or when we're taking, like this time, when we're lambing and we're calving, when we start taking animals to the mountain ranges. And I can't provide them any benefits. I pay them a certain salary, and they understand I try to pay them as best wage I can, so that they have something to live on. It's just a fact, I think, that some of the areas that we live in, that will move from job to job sometimes. And it does make it frustrated that if they get hurt, not only does it hurt them, it hurts me. And so that's a frustrating aspect from trying to stimulate the economy, especially in a rural area.
Sybil, I know you have a farm as well.
I do. We have a 160-acre family farm, fourth generation family farming, and
And
have
you're
to be-
in, is
we're
it
in
Ohio?
Southern Ohio. We happen to be certified organic, so we have a special interest in really healthful food. And I'm struck by the irony that here where many of us are working hard to bring healthful food to the American table, and yet our own health gets neglected. And we contribute to that ourselves. So the fact that you've allowed us to come here and talk today gives us a chance to make sure we're sticking up for our own needs for health care. I was struck earlier by this idea that this is a teachable moment for us, that innovation, and as you put it, you said inventiveness, comes from the rural community. So maybe we can come up with some new ways of delivering health care that could be transferable to suburban and urban areas. And I'm sure this is being done some places, but certainly not in my community. We don't have anything like a mobile van that would come into our communities with primary care, preventive care. It could come in on a scheduled basis. We're real good at the local level in organizing people to come to the township building on a certain day for a certain kind of appointment. That might not cost a lot, and we would make sure it was heavily utilized, there would be no downtime. So that's an idea I think that maybe could work, that we could do as a pilot project maybe in Ohio. So that came to my mind.
Do you have coverage right now in your farm? Do you provide coverage right now on your
We
farm?
only have one employee.
Okay.
We're doing our own work, and then we farm on the halves with another guy, the old way of doing that. Where he has some of the equipment we don't have. He comes in, does the planning of certain of our crops. We also have Angus cattle, so we have a certified organic beef operation too. We have one man that helps us part-time with the cattle, and we don't give him any insurance. I don't even know if he has insurance. Currently, he's covered with workers' comp, but, at our farm, but I really don't know whether he has insurance. I work a full-time job in town, and I have insurance, but even there, the way you were talking, I have a $2,000 deductible now, so by the time it really gets in my pocket, all this insurance I've already put out beyond the premium payment, a lot of out-of-pocket expenses. So that's not working anymore either.
Nancy, if I might make one comment, though, that Sybil mentioned about, mobile units that are out there, those they can be temporary, effective approaches, but those are Band-Aid approaches, I really think, especially to rural areas. I would like to see, incentives for physicians to come to rural areas. You mentioned before how urban counterparts, they want to go to those areas because they are attracted to go to those areas. We need permanent locations. I know we don't have the populations to justify it, as some urban areas do, but I think we can look at greater areas, that kind of regional approaches that do bring the specialists, that do bring the same health care that our urban counterparts, our urban friends, enjoy, that we shouldn't have that trade-off.
But even from those locations, perhaps have a mobile
Correct.
unit
And then
spread out from the community level.
Congressman?
I think you need both. You need what I call country docs, general practitioners in the rural areas. Obviously, you're not going to have specialists in rural areas, but those specialists, for example, in my hometown, we have one of these RV-looking things that comes to, buses that comes to town once a week, and on board's a pediatrician. And it keeps everybody in our town from having to take a whole day off work without pay to take their child 40 minutes away to a pediatrician. So I think and you mentioned preventive, I think, for prostate screenings, for breast screening, for all the different preventive things that need to be done, that we know can save us a lot of money, plus it's the right thing to do. I think for preventive care and for some specialties, I think it makes a lot of sense, to your point. And to your point, I couldn't agree more. We've got to have more general practitioners locating in rural America. That's a big problem. And finally, if I could just say this, that because I know you mentioned about changing our way of life, and I don't want to change our way of life either. No one in Washington is talking about nationalized or socialized health care. You got to listen to talk radio to hear that. That is not on the table. What we're talking about is trying to make health care more affordable, more accessible. We're talking about trying to address this rural crisis that we have. And quite frankly, Nancy had mentioned I'm in the Blue Dog Coalition, which is a group of, it's just a name for conservative Democrats, fiscally conservative Democrats. And a lot of people say, why are we discussing health care reform when we, inherited this record deficit? That's the very reason why we got to. 40 cents out of every dollar today goes to Social Security, Medicare, Medicaid, and S-chip. If we do nothing, it'll be 100% by 2040, which means we'll no longer have a Department of Agriculture, Department of Defense, or anything else. We'll be a government who's in the business solely of providing Social Security, Medicare, Medicaid, and S-chip. So that's the very reason why we've got to do it now, is we've got to contain the cost of health care. And one of the ways we can do it, as you mentioned, 40% of the cost, in a lot of instances, doesn't go to provide one's care. It goes for the administrative cost and the slick TV ads that we see trying to tell you which drug to tell your doctor you need. And I'll shut up. I'm sorry.
No, very good. And how do we preserve what works in these communities and what attracts people to live there, and yet provide some of the services that we know people need? I think that's part of this discussion as well. Terry, you've had your hand up for a while.
Yes, I'm Terry Dillon. I'm the director of the National Rural Health Research Center, and we are funded by several contracts and cooperative agreement with HRSA. And we, for example, run the Technical Assistance and Services Center that supports the Medicare Flex program. So a big part of my job is going around the country talking to hospital groups, talking to communities, etc. And first of all, I just want to say that the economic crisis we're talking about in healthcare is very directly related to all the economic problems we're having in rural communities. Several times I'll go out to a hospital that has closed, and the impact on that town is really catastrophic. There's an impact on emergency medical services. In other words, the fragile infrastructure of rural health care is something that needs to be protected. And at the top, we also need to protect the programs that are working right now. The Medicare Flex program has been extraordinarily successful in creating infrastructure at the state level. We never had that before, but again, that program comes out of HRSA. I'm working on the Delta Rural Hospital Performance Improvement Program within Arkansas, for example. Extraordinary leadership is coming out of there. A lot of good things are happening. But the impact of this economic crisis on hospitals has been very, very negative as well. And the Critical Access Hospital Program, where we have 1,300, we've got about 1,300 critical access hospitals, and they had been able to get their head above water financially, and now they're starting to lose money. Because in rural America, you don't turn people away from hospitals. I mean, or for clinics. I mean, those are your neighbors, your friends, etc. So the solutions are going to come on a community-wide basis. We're going to need to support the infrastructure at the top as well. The Federal Office of Rural Health Policy has been just a long-time champion of rural America, and we need to continue to support them. At the state level, we have hospital associations, rural health associations, medical associations, offices of rural health, etc. So at that state level, there is a creation of infrastructure, but that too is fragile. And then finally, at the local level, we have these kind of patchwork quilts that have been put out that are presently covering folks. But I grow concerns that if we start to lose our hospitals, and that in turn leads to the exodus of physicians and emergency medical services, we are really going to be in trouble here. So we've all got to work together, and I want to stress that aspect.
Do you want to say something?
Just to come in on behind the point, Terry, that you just made, and that is trying to maintain a very fragile infrastructure, particularly thinking about the healthcare providers in those rural communities, from mental health providers, psychologists, physicians, nurse practitioners, oral health providers, and so on. In the Recovery Act, there was a significant additional down payment to try and keep those providers in place through some dollars directed to the National Health Service Corps, which is one of the federal programs that puts physicians, advanced practice nurses, PAs, and others out into rural and some urban communities. Fortunately, that Recovery Act money will double the number of healthcare providers available to come through that program. But I think we probably all agree that's not nearly enough. It's just a down payment on what over the long haul, because of what you just described, is going to be needed in order to preserve some of that infrastructure.
And Mary, another really positive thing out of that bill was the support for electronic health records and telehealth. We have the capability now to do work in rural communities from remote locations. And the reimbursement is not aligned to do that, and we need support in that regard as well.
I want to call on Rhonda over here, who's a farmer from Missouri. What are you seeing out of Missouri in terms of access to insurance and your health care needs?
Well, in Missouri, my name is Rhonda Perry, and I live on a livestock and grain farm in central Missouri in Howard County, and I also work with the Missouri Rural Crisis Center. And I think Missouri was fortunate to be one of the states that was really looked at when the Access Project did their multi-state research that you mentioned earlier, and it really gave us some justification for all the things we saw going on. We saw it really is true. It isn't just that our neighbors are seeing this. It really is a fact of life for us in Missouri. And I think one of the really astounding things is that, and you mentioned this earlier, 90% of farmers have insurance. You know, we're not shirkers. We want to have insurance. We want to be able to pay for it. We want to be able to carry our own weight. In part, we have insurance because we have to protect our farming operations. If we have a medical disaster, it could be our farm that pays for that. And so I think there are a lot of farmers who are in situations in which we're spending 15% of our income on a catastrophic policy with a $5,000 deductible. And we're doing that not because we can really use that insurance, but because we have to have it to protect ourselves and our future livelihoods, as you all raised earlier. But the problem with this is that the other astounding thing, which we found in Missouri as well, is that 30% of those farmers are purchasing that insurance on the individual market. And the individual marketplace is the marketplace that puts us into a situation in which we have to rely on the most costly policies, which are the high premium, high deductible policies. So farmers in particular are pushed into this marketplace that is completely not, inconducive to an efficient healthcare system. And on the individual market is one in which up to 40% of what we pay in premiums can be used for administrative costs.
That's what Rhonda was talking about. That's for the ads.
Versus the pools, which can be as low as 10% or Medicaid as low as 3%. So I think that sort of leads us to a couple of possibilities, which are we've got to be able to have access to pools. Farmers and small businesses and nonprofits. We've got to figure out ways to be able to pool our insurance. But the other thing is, it seems like we've got to do some regulation of this individual private marketplace. I mean, if 30% of us are dealing in the private marketplace, which is pushing us into the highest, most costly policies of all, I think we have to have some accountability there. We have to be assured that there's going to be reasonably priced premium policies that are low deductible. And right now they don't even have to offer that. I mean, in Missouri, the individual marketplace is just completely unfettered, unregulated in any way. And so that puts us in a really bad situation in terms of family farmers. And so, if we're not lucky enough to be able to spend 50% of our income on, probably a really crappy policy, well, then we get to go get a job in town. And as we all know, the jobs that we're based in Missouri, even if you have health insurance, health care costs in Missouri are rising 4 times faster than the wages. So even if we can get a job in town that has insurance, we're still not going to make out under this current system. But I do think there are some great examples, and I just heard earlier from the fishermen who've put together a cooperative effort of insurance among fishermen that sound like this could be some possibilities for us.
That's you, JJ, right? You
That's me.
Want to talk about the fishermen?
Yeah, I'd love to. I really appreciate being here as well. And
you're from Maine, is that right?
Massachusetts.
Massachusetts.
Yeah. But I work with fishermen around the country and really appreciate that you've all included fishermen in this group. I can speak to that. It's fishermen have very similar issues. Fishing families are 3 to 4 times more likely to be uninsured. Seasonal work, it's the most dangerous job in the country. Unfortunately, insurance underwriters also watch The Deadliest Catch and read The Perfect Storm. So the other thing I can speak to, I think, is I've been running since 1997 one of these innovative demonstration programs, and also happen to live in Massachusetts, so I can speak to hope. Because prior to the launch of our program, 43% of fishing families were uninsured. And 5 years later, that was down to 13%, and now the state has near universal coverage.
And this is, you might talk a little bit about what Massachusetts has done.
Okay.
People may not be familiar with it.
Sure. What Massachusetts, there are many things that Massachusetts has done that we did also. One of them is to address the issue that you were just raising, the individual market, by making a sort of exchange where for lower income families there are products that are available and there's a sliding scale. We have that as well for our plan. In 1997, the first thing that we did was group fishermen together, then to get a market competitive rate, and then we use a sliding scale so that fishermen, so it's affordable at every different income level. That brings folks into the system. So when you're uninsured, you're not paying into the system, but when you have coverage, the fisherman actually pays 60% of the cost of our plan. In return, they get comprehensive coverage. We don't have deductibles. We don't have exclusions for pre-existing conditions. We don't rate based on age. And similarly then in Massachusetts, that's the case as well. And then there are programs for folks that are available for folks who are not through employer groups, but there are more group plans that the state has on a statewide basis. But really, the fishermen, the rural workers, the system is flawed. And I just wanted to address another solution that I would strongly suggest get funded in the healthcare reform effort that we found, a very cost-effective solution, and that is community-based outreach. The majority of Americans, as we all know, have coverage through their employer groups. And the employer groups invest in their employees. One of the ways they do that is through Human Resources Department. Helps folks navigate the healthcare system, fill out the forms, et cetera. There's oftentimes no analogous investment in human capital among rural workers. And we realized right away that there's no Human Resources Department for the fishing industry. You can't just sort of pop down to the cafeteria and get your blood pressure checked, or just stop down at the office and let them know that you just got married or you just had a child. So we hire fishermen and fishermen's wives. We staff offices in the fishing areas to perform those services for us. And we've had tremendous success. You're talking about 40 cents on the dollar. We have to bill to individuals. Again, we group fishermen together, but they don't all come to some office. Yet our administrative costs are 13% of revenue. One of the ways that we're able to do this is because we don't have big glossy ads. We don't have ads. Fishermen don't want to hear from guys like me in ties. They want to hear from each other. And so, again, our workers literally go out and walk the docks, and they know when to do that. They know that if it's a nice day and it's the first day of the season, you might as well stay in the office. But if the wind's blowing, people are tied up, get down to the docks. So it's very efficient and cost-effective. The other thing is we've been able to implement, based on their feedback, innovative medical education programs. For example, if fishermen are often contracted workers, paid a percentage of catch. If you're 2 days into a 14-week trip and your tooth blows up and you have an infection, you have there are two sources, two healthcare concerns. One is the tooth, and the second is telling the captain, the mate, the other crew members that they have to turn around and incur the costs of the fuel, all the bait that they, not only for this trip, but then the next trip that they'll have to pay it off. So they'll, pull the tooth. And so we have hired a renowned fisherman who is a trained safety expert to go out to the individual captains and train them in CPR and first aid. Again, something that we came up with because of our work with the community. And I think it's absolutely essential that type of funding is available.
It's really interesting. I want to call on Leon and Donna, who are over here, who are also farmers.
Yes, we're from northwest Kansas. We farm and ranch and have a corn, wheat, and alfalfa hay, and we have a cow-calf herd and raise high-quality beef. We thank you for inviting us here so we can share our views. When Donna and I decided to start a family, we had she had an unforeseen complication called preeclampsia, which can cause very high blood pressure and other complications for the mother. It's also very hard on the unborn child. This affected both of her pregnancy. As a result, we had 2 premature baby girls. Our youngest was born at 3.5 pounds with no complications at the present age of 11. Our oldest was born at 25 weeks and weighed 11 3/4 ounces, less than a full can of pop. She was 9 5/8 inches tall. We're very blessed to live near an outstanding set of doctors with fine facility. Our doctors and hospital is 25 miles away with no traffic. It'll be closer than the 6 blocks we took this morning. Right now, there's 5 doctors in the facility, and they're all family practice doctors, and they see everything. We have 2 older doctors and 3 younger doctors, and 2 of them are a husband and wife team. In the same complex, there is also a younger dentist, and we also have an eye doctor in the town, and we're 60 miles from a stoplight.
You're lucky then. Very lucky. Yeah.
These doctors did not deliver our babies, but because of complications, but they do deliver babies with normal birth. The doctors were on top of the diagnosis and had us at the proper place when the time was critical. Our babies were born in Wichita Wesleyan Medical Center, 4 hours away, and they were both in the NICU, neonatal intensive care unit for a time. My oldest daughter, which is now 14, has a condition called retinopathy of prematurity, which is a scarring of the retina due to becoming detached, and which leaves her legally blind and a braille reader. When seeing eye specialists, we would travel 90 miles south to Garden City, where special eye doctors would fly into once a month. I have no complaints for the accessibility and the quality of health care in my area, thanks to the commitment of our county in maintaining the facility and recruiting doctors. Like I said before, we're blessed to live where we do in Gove County, Kansas. But our county has, when they recruited doctors, they had to make sure, had to guarantee them they were going to make a certain amount of money, had to buy them a member at the country club 60 miles away, had to make sure everything, and now it's a place where people want to go back to, and the young doctors are coming there, and it serves quite a wide area, and we're really a success story, I think. The downfall is I have 2 friends that serve on the hospital board, and I had called them after I was called to come to this meeting, and I called them, and they said the biggest problem we have is we can't hire enough help at the wages that the Medicare reimburses us at.
Help meaning nurses and other...
Yeah, the doctors are there, but the nurses and right now they're looking for a hospital administrator, and we just can't keep up with the wages that everybody's hiring away from us for. And they're doing a wonderful job, but it's all coming back to us farmers on the property tax to support our hospital. And so is I'm on the school board. So is our school coming back to the property tax. And you only come to that well so many times, and we're tapped that way. Dawn and I have had health insurance the whole time. I'd like to say I started with nothing, and I still have most of it.
So you purchase your own insurance?
We purchase our own health insurance, but we make it a priority to purchase our own health insurance. Our oldest daughter, the bill was a computer printout that high, $800,000 or more, and we wouldn't even pay the interest on with our premiums. But our premiums just before we left this week, it's hard, but it's not bad. We are in a self-employed group of Blue Cross Blue Shield of Kansas, and we were $500 last year. We just got the notice we'll be $566 a month this year. Well, that's over 10, 12, 11% increase. I don't know. It's hard for the insurance part of it, and I do know some of my friends and colleagues that don't have insurance, and some of them can't afford it. Some of them choose to not afford it. I think that we have a success story in our community as far as the health care, but we have to do something about the costs and the reimbursement of health care. I can't document this. I was told the story over the tailgate of a pickup about a man whose wife was in the hospital last 6 months of her life, had a blood clot. She had 132 doctors come see her, and he felt like they were just saying, well, go get your $150 a day, Medicare will pay for it, do your consultant. And that's why we can't do that when you only have 4 doctors in a hospital. We can't abuse the system to try to pad our pockets, and rural people won't do that anyway. We're got integrity. We're going to do we're going to get what we pay for, and we're not going to cheat the system. So I'm feeling like some of the problems that we have isn't with the rural America as much in the cost of doctors, their insurance they have to have, and as far as one of the things that came to my mind that we talked about mobile units, we have mobile specialty units come out of my mother had a bone scan down a week ago, and they have a mobile unit come out to do that from an hour and a half away to our hospital. And it must be the doctors try to do recruiting themselves, because we have lots of preceptors that come to train there to do some interns there. It was a lot tougher to pay our health insurance when we were younger, just starting with kids. But God's blessed us, and we're doing well now. We're able to keep up with our premiums. But I'm concerned about the expenses more than I am in my particular situation of access. I feel like I said, we're 60 miles away from a fairly good hospital. Our local hospital is 20 miles away. Our kids go to school 30 miles away. If they have a problem, heart attack, what have you, have to rush somebody to Wichita, we have to fly for life. We just paid for a helicopter pad there. Our county just keeps up. We're trying to stay cutting edge so we don't have this we can't recruit doctors. But that's our story.
It sounds like you've been able to stave off the recruitment problems that some other areas have had.
But it's been an investment in the community by the county.
Sounds like it is. Wayne, I want to get you in here. You're from Maine, is that correct?
That's right. I'm a recovering pediatrician. I got into medicine the same time the government got into Medicare, and I knocked around rural America. We farm 150 rocky old acres in Maine and have a diversified old family farm, some hay, some organic fruits and vegetables on the U-Pick operation. I'm on Medicare. My wife's insured, but the word's gotten around the neighborhood that although I no longer see patients, people come over to talk about their health issues. There depends a lot. I have an 80-year-old neighbor who has never, man or boy, seen a doctor as a patient. He knows a lot about health care. He lost his wife to diabetes after all the catastrophes that happened. But sort of makes the point that we need doctors that patients can be sure work for them and whose word they can take. I'd like to tell you about the young couple down the road that they're struggling mightily to get an organic fruit and vegetable operation going. The kids are on Medicaid. They're on Girago, which is a state subsidized insurance product that knocks their annual payment for a $2,500 deductible down to $6,000 a year from $12,000 a year. But without that supplement, they would be paying that $12,000 a year. Now, for them and for most rural people, cost is the bottom line. And it just offends me. You know, even clear out in rural Maine, we get the electronic edition of New York Times. And you remember the commercials were saying the government's got to stay out of offering a competing policy because they can undercut us 15-18%. You know, they can't offer a competing insurance policy.
This is the public plan idea?
That's the public plan. Well, for my neighbors, that is $2,000 or $3,000 a year out of their pocket to subsidize the commercial carrier. Do you follow what I'm saying? That the organization that you ran, Nancy Ann, can, in the Clinton administration, can offer an excellent
Medicare
product.
program, yeah.
Medicare-type program can offer an excellent product for $2,000 or $3,000 a year, less expensively than the commercials can.
Well, this relates to the administrative costs that
So to offer that commercial plan, we're talking about a wealth transfer from struggling poor rural families to investor-owned companies. And that's the kind of wealth transfer that we don't really need right now. So the challenge is, if the commercials want to offer that product, they ought to show that they can offer a product as economically as the government product. We're always talking about the inefficiency of the federal government. I guess I'd finish with the product that even rural America worries about, the out-year cost. You know, the federal, the health care costs are eating us alive. It dwarfs the Social Security issue. And we've got to think terribly carefully about how we organize to manage long-term health care costs. We don't have time to really get into that, but that's a terribly complicated long-term question. One last parting shot. In my rather too long career, the number of docs in this country has gone from 160,000 up to 860,000. And we're talking about a doctor shortage. Somebody's writing in the New York Times, can we do health care reform with our doctor shortage? Well, it's not a doctor shortage, it's a maldistribution. And it's strictly a function of our screwed up system. And saying we can't do reform because of our doctor shortage is like saying, you know I need this appendectomy, but can't we put it off? My belly hurts so bad. We just got to get on with fixing the problem if we ever want to get out of this physician maldistribution. Thank you.
Thank you, Doctor. Bill, you've had your hand up.
This really dovetails into what Dr. Myers was saying, in that we really have to recognize that rural communities have been innovative in their delivery models. We do have primary care rural health clinics that are mobile, but we rely upon physician assistants and nurse practitioners, and rural communities have really been on the forefront of using innovative health professionals to deliver care and extend the reach of health care for mental health, primary care, oral health. And if we do health care reform, we give people an insurance card, but the provider that they have access to isn't recognized by that insurance card, we haven't done anything for them.
So what do we need to do?
Well, you need to recognize those state-licensed health professionals where the states have said, you know what, we can't get physicians out to these areas. We're going to use PAs, we're going to use nurse practitioners, we're going to use nurse midwives or something else to say, then we're going to recognize. And if you're an insurance company and you're going to sell a product in that market, then you have to recognize the delivery model that works in that market. Otherwise, we're buying something that is totally worthless to that individual. The Rural Health Clinics program works because we use PAs, NPs, nurse midwives, and others in addition to physicians. It doesn't mean to the exclusion, but it recognizes that it's not just a physician delivery model There are a variety of providers out there who are qualified, able, and available to go out to those areas to deliver care, and if we don't recognize them, we fall well short of our goal.
So you would rely on what the state scope of practice rules are?
Yeah, I mean, otherwise, I mean, we've spent an inordinate amount of time debating and working with CMS on what are you going to do and will you recognize these providers to say, you know what, if the state has determined that these individuals are qualified and they're capable, it's within their scope of practice, and it's a service that's going to be covered by Medicare or whatever the insurance product is, then we're going to cover that service. So your policy covers the service, and it just simply recognizes whoever the state has determined is qualified to provide that service in the scope of practice that they've determined we're going to do it. Otherwise, you go in and you get the state to convince or to recognize you, but now you have to go out and fight the second battle to get the insurance provider, whether it's a government insurance or commercial insurance, to recognize you, and that just defeats the whole purpose. If the state says you're qualified and the service is going to be covered, if I'm going to get, suture, I have a wound that has to be sutured, and that's what I go in to get, and I get it by an individual who's licensed by my state to do that, then my insurance policy should cover it.
And just for my clarification, I do remember the issues around CMS's rules, Medicare and Medicaid, but do most commercial insurance companies, like people here, have insurance in the individual market? So would their Blue Cross plan
depends on whether they're network or non-network. In the network plans, it's been a problem because for rural health clinics, we have PAs and NPs, and the network models will come in and say, well, we'll only allow physicians to be part of our network. We won't recognize PAs or NPs as part of our network. Now, on a fee-for-service policy, oftentimes it's a little bit easier, but if it's a network policy, they'll say, well, you got to be part of our network, and we only allow physicians to be part of our network. So we have to expand that and say, fine, if you want to have a network, if that's the model, but recognize the diversity of providers who are out there to be part of that network. Don't be so narrow to just recognize one type of provider.
And of course, the network plans are less expensive.
Sure.
Which goes back to our argument before. That's what people will be able to afford, so we need to make
well,
sure.
Unless you deal with it through a community rating. I mean, some of the innovative models like they've got up with a fisherman, I mean, there are ways to deal with that, and I don't know whether your plan recognizes other providers besides physicians, but I mean, you can do a pooling at a product level that helps to get efficiencies and lower cost. But again, unless you're recognizing the providers that those individuals have access to, you don't necessarily have to do it through a network model.
I need to call on my friend from the Farm Bureau here.
Thank you.
What do you all see?
President of the American Farm Bureau Federation. It's a pleasure to be able to be here and talk about an issue that's been front and center ever since I've been involved in Farm Bureau as an organization. I come from a small town, Columbus, Texas, about 70 miles west of Houston, county seat. Congressman, 3 stoplights, routinely ignored residents because they weren't there when they learned how to drive.
Now, he's not endorsing running the red lights there.
And just on a personal note, my sister is the administrator of the lab in our local community hospital. We're somewhat fortunate because we're a county seat, and we still have a fairly decent medical facility. But we accomplished that by taking away resources or consolidating resources from the 2 smaller communities that are in the county, thus making it more difficult for those individuals to access health care. You know, we've had a lot of discussion about the issues that are out there, and I won't reiterate those. One solution that we tried, our state associations tried, and are still trying to do are group health plans, the pooling that Rhonda mentioned. Now, the only problem with that is that farmers and ranchers tend to be older, and so that pool is slightly less healthy, probably, than just a composite of the American population. And then so you start getting adverse selection by those young farmers and ranchers who are capable of going to the private market. And so the pooling and the group health plan thing has worked, but I can't say it's worked as well as probably it ought to. This report, and I didn't get a chance to look at it in its entirety, but referenced the Access Project, and I looked at some of that before I came over here. Just 2 points. And this gets to the real economic part of the matter for farmers and ranchers. The farmers and ranchers who reported financial problems spent almost 1/2 of their income on insurance premiums and out-of-pocket health costs. And 1/4 of the respondents reported that health care expenses contributed to their overall financial problems and caused them to postpone or delay making needed investments on the farm.
So it's just like small businesses,
Exactly.
just like large business, really.
That's what farming and ranching is small business. And, USDA makes a lot of reference to the amount of non-farm income now that's supporting farmers. I would be curious as to how much of that non-farm income is derived, because the economic decision by that family is to get group health coverage as opposed to whatever dollars they maybe could retain, from the extra.
I mean, non-farm income is just a way of saying people go off the farm to get a job in order to get health insurance.
And Jody, I hear that over and over again.
Yeah, you said that too, Jody.
So it's a huge issue, and we look forward to help assisting in finding solutions.
And we need farmers producing good food right now.
Absolutely.
Healthy food. Dr. Knudsen, you said you had a comment on this.
Yes, I'm Dr. Lon Knudsen from the National Community Research Center here at the University of Chicago. It's actually based in Bethesda. However, when this survey was conducted, I was part of the University of North Dakota Center for Rural Health, and we did this survey in partnership with the Access Project. And one of the things that we found, to your point, 38% of the respondents said that they worked off-farm specifically. If you look overall at their income, and a number of their spouses also then worked off-farm. And I think one of the things that I was struck about, because I grew up on a farm in North Dakota, was that people are making more and more decisions based on their access to health insurance. And one of the things that was really clear, as you mentioned, farmers and ranchers on average are older. I know, speaking with our friends from Montana, their sons are not going to be able to take over the ranching business because of the concern about the financial viability and the challenges that they see ahead being able to maintain a farm operation or ranch operation and also maintain health insurance. But I think one of the things that sometimes also gets lost in this discussion is that not only do these farm and ranch families have challenges getting health insurance, if they decide to stay within their farm and purchase in the individual market, any person in that family who has a chronic disease or any kind of pre-existing condition will ratchet up their health insurance premiums. And one of the things that many of the respondents in this survey identified doing was taking advantage of the high-risk pools that are available in a number of states to be able to peel off that person, if you will, with these chronic health problems. But, again, it makes it very difficult because one farm family said they had one child on one health insurance product, a mother on another, and the remainder of the family on yet another. And we know how complicated health insurance is to begin with. And when you have a family that is that fragmented when they're accessing health care, it makes it really, really difficult. But I do think there's some real good innovation in looking at, for example, what you folks have done with the fishermen. And there probably are some really good lessons to be learned there.
I agree. Lisa, do you have any comments from the Family Farmers Coalition?
Well, again, thank you for allowing us to come today. Some of our member groups are here, and I think they've spoken really well to the problems. I know in particular one of our Wisconsin dairy farmers works 24/7 basically, as dairy farmers do. His wife works, I believe, full-time at Walmart for them to have health insurance for them and their 2-year-old daughter. And still they go without the preventive care. And I think, as Sybil said, the farmers are trying to raise healthy food. We're becoming more and more of what a concern that is and a need here. But our farmers need to be protected, and people who work in rural communities protected so they can afford to bring us that good food as well. Okay.
Yeah, that was ironic when you pointed out the challenge of people who are trying to produce healthy food staying healthy themselves. It was. I want to make sure, Neil. Oh, I'm sorry. John.
I'm John Bailey. I'm the Director of Research and Analysis at the Center for Rural Affairs in Lyons, Nebraska, population 962, and it's a no stoplight.
Sorry, I didn't start.
You did. We're going to be hearing in, this is being live streamed, so I think we're going to be hearing in from others who want to weigh in on this contest with the congressman here.
We're also releasing a report this morning. I'd like you to have a copy. It's entitled The Causes and Consequences of Rural Uninsured and Underinsured. And it raises up an issue that I think several of us have alluded to this morning, and that is the connection between affordable and meaningful health care coverage and entrepreneurship. And as you heard from several people here today, they're all entrepreneurs, and the rural economy is based so much on entrepreneurship, whether it be farming, ranching, fishing, or small business. And your report points out the figures on small business coverage in rural America, farm and ranch coverage in rural America. So how do we provide affordable and meaningful coverage for our rural entrepreneurs, which are such a big part of our rural economy? If we don't solve the healthcare issues of small businesses and farmers and ranchers and fishermen in rural areas, we won't have an entrepreneurial economy, and that means we won't have much of an economy in rural America. Congress has done much to promote initiatives to promote entrepreneurship in rural America. The President is very supportive of those. And this is another part of entrepreneurship. How do we allow people to follow their dreams, as Ted talked about right from the start? These are people who have done everything we've asked them to. They have an idea, they've saved money, they've started a business. Well, they can't afford health insurance for themselves, their families, and usually for any employees they have. And it puts their business at risk, it puts their farm at risk. So we really need to resolve this problem if we're going to have any kind of economy in rural America. One other issue I wanted to point out, and Lisa just talked about it, is the issue of prevention. How do we have prevention services? How do we live healthier lives in rural America? We have higher rates of obesity, higher rates of almost every chronic condition and disease, most of which are preventable in rural America. So how do we do that? Of course, the food issue is so important, and more resources that allow for preventative activities, both providers and community resources that allow for that.
Thanks.
Thank you for having me.
Thank you for being here, and thanks for the report. Charles, you want to say something?
2 or 3 quick comments. First of all, we're honored to be here, and this is tremendous community expertise is in this room. I'd like to thank the President. I think he realizes the interdependence of urban and rural systems. But I want to follow on John's point and chat about what Terry said. We talk a lot about rural entrepreneurship, but the largest predictor of uninsurance in non-adjacent counties is, do you work for a small business? So I want to make 3 points. Granularity is key, systems approaches are essential, and we have to think about how we frame new opportunities with intermediaries. There is no rural America. Everyone here will say, once you've seen one rural community, well, you've seen one rural community. And that's very critical to how you think about this, because the micropolitan areas in the adjacent counties are going to do quite well. But in our frontier and remote counties, and in our high poverty counties, you're going to need very different systems. Bob made an important point, but it's very, very key to think about it. 90% of farm income right now comes off the farm. 2/3 of farm families, one of them works off. But the reality is, in rural economies, 5% more work in their own business, but they make $17,000 a year. And in urban areas, it's 35. So right away, how we deal with that is very, very huge in terms of the return for foreign family income. 2 points. I think we have a wonderful opportunity to think about the critical access hospitals and the FLEX program. That was an innovation in public-private link that built a geography around it. Going to our fishermen, building a community understanding around a healthy community framework, which this wonderful Office of Rural Health calls, and we're so honored that Dr. Wakefield is here because you have a rural thinker. The reality is, in our remote rural areas, if we were thinking about the fact that human services must link to health services, and if we were thinking about remote campuses in which initiatives that link healthy food systems from farmers to Medicare and Medicare, where seniors aging in place could link to health care for workers. And we were building new demonstrations that said, here's a campus in a remote community, but we're going to fulfill these functions, much like the fishermen did. There's a very unique opportunity here. I would also say USDA could be a huge partner in this. We have two leaders with very wise rural understandings in those 2 departments that have been governors, and I would urge us to think about new collaborations in regional campuses for these services.
That's a great idea. And Governor Vilsack, from day one, has been very interested in working on this, as you say, with Secretary Vilsack and Secretary Sebelius. That's a great idea. I wanted to just recognize Neil, and then I'm going to let the Congressman defend his stoplight record. Oh, yeah, I'm sorry, Roger, I didn't call on you either, but Neil, go ahead.
Well, so I want okay. I really appreciate the opportunity to be here. I think the Congressman identified that the struggle, trying to figure out how you're going to contain costs. And I want to say first, I think it's really important now, more than ever, to be really clear about what that means and identifying the cost of delivery as being the challenge as opposed to the sort of expense of the individual, because seniors and the growing senior population are rightfully scared now, and what they have to show for their life's work now is Medicare and Social Security, because the retirement's gone and so on. And I think it's so important to keep that in mind, because it's easy to say, we're going to have a problem, we're going to have to cut it somewhere. Where are we going to cut it? And I want to come back. I'm not a healthcare expert, but I think Chuck at bringing the systems points home is really important. And I think about a couple things. One is, like, when I grew up, we had school lunches, right? The women worked, they cooked out of the USDA's flour, and lots of beets got dumped, and one kid ate them, but you got a hot meal every day. And as those systems changed, and as the industries that make prepared foods came in, I got dialysis clinics at 36 in Lindale in South Minneapolis where I work. I got dialysis clinics coming in Hayward, Wisconsin, where I recreate with my wife occasionally. Dialysis clinics in rural Wisconsin. There was a chemo clinic in Fond du Lac, Wisconsin, in Fox Valley, where my mom finished her career and ultimately died of cancer. But why? Because of the stuff that's going on around. Having to have those kinds of delivery systems. But the dialysis stuff bugs me the most, because it's like a reflection of diabetes and obesity and the economic opportunities that come from, and just the kind of improvement in your quality of life that come from either growing your own little garden or getting at the farmer's market in the summertime or beginning to produce for the marketplace. The connections to USDA, the opportunities for economic development that come from producing local foods. This is not just about having a robust and a diverse system of food production. It's about bringing the schools and the education system back in here. We got free and reduced lunches. Why don't we make them something that's useful, that provides economic benefit? I mean, the thing that the president has done so well is connecting the dots, and there's a lot of dots to connect here, but we're going to save money is to get us down on diabetes, down on health, on heart disease, and, up on nutrition. And we don't have to debate about junk food, but there is no debate about it's good to eat fresh foods, and there's economic opportunity with it. And I hope we can find ways to continue raising that up and putting it out front here. And I'll say one last thing. One interesting thing we've just discovered is that Latino immigrants, which we've done a fair amount of work with in communities, so they struggle with jobs, they struggle with status, they struggle with access to health care. Turns out that a lot of them, especially those from Mexico, come from farming backgrounds. And lo and behold, when you open up a community garden or you have some opportunity that connects to them, not in the dominant sort of, here's how you got to have your plots way, they come in droves because they want to grow vegetables, and they bring their kids, and kids keep out of trouble. Some of them actually want to farm. So we've actually now started to do some work developing small-scale free-range chicken cooperative production systems that you can actually make a living. The capital costs aren't that much. The local community loves it. And you've taken families that are out of, it's not like a systems thing yet, but you take a family that struggles and you give them the opportunity as entrepreneurs to move up and out. And this is it's one small example, but there's, I think, a lot of others out there that are possible if only we encourage it and don't discourage the opportunities around it. So thank you so much.
That's great, and I appreciate your highlighting prevention and wellness, which is, as you say, a big part of President Obama's message. Roger, you're going to have the last word, then I'm going to let the Congressman wrap us up.
Thank you very much for doing this. Our national convention was held about a month and a half ago.
This is the Farmers Union.
The National Farmers Union National Convention. And at that, we routinely adopt a special order of business or several special orders of business. This year, we did that again. And one of those special orders of business was dealing with rural health care. This is a huge issue for farmers. It has been for all of my life. I grew up on a family farm. I lived it personally. I know, as a lot of folks have said, that it is the principal reason a lot of farm spouses go look for work. is to get that insurance coverage. But in all of the things that I was going to say have largely been said except for one, and that is that we have to make sure that we don't forget that healthcare is about people. On the way over here, sitting in the cab going nowhere, I got an email from one of our members who heard that I was coming to this meeting and had a long story about what had happened in their family. And he is actually a grandpa, but he was talking about his son and daughter and the fact that they had one of his children had gotten married and had a baby. And that first baby that they had, of course, pregnancy wasn't covered in the health care policy that they had. And 8 years later, they are still paying for the costs associated with having that kid. They're still paying because a lot of you said about out in the country, we're going to make sure we take care of our bills. Well, if you end up with several $100,000 of costs as a young couple just starting out on the farm to have a baby, and every dollar is worth a whole lot. 8 years later, you're still paying for that first baby. There's something wrong with the system that imposes that sort of a burden on young folks for the rest of their lives, as it may well be. So the need here is very evident. There have been a lot of suggestions, but there's no question that the problem really does need to be addressed and needs to be addressed. And so thank you very much for pulling this forum together.
Thank you, and thanks for bringing it home, because you're right, we do need to keep that in mind. Congressman?
Thanks. I want to thank Nancy Ann and Mary for all involved in putting this together, and I want to commend you two on bringing people in from outside of Washington and listening to them, because I think this is so critical as we try to begin this health care reform debate. There's a lot of misinformation out there. No one knows exactly what it's going to look like because it hasn't been written yet. I'm fortunate to be on one or two committees that will do most of the writing, Energy and Commerce, and I'm on the Health Subcommittee. There's 51 of us that are conservative Democrats, and I call the Blue Dog Coalition. I chair their health care task force. And we're going to be very involved in this whole process as well. But, I can't emphasize enough that, this is about containing the cost. It's about making health care affordable and accessible. It's about forcing the private sector to do the right thing. Because we've heard so many stories about the many failures we have with the system the way it currently is. This is not about socialized or nationalized health care. There may very well be a public plan option that will compete with private plans to get the private plans to start doing right. That's one of the things that we're going to have to contemplate and consider. But the reality is half folks already have national health care. It's called Medicare, Medicaid, and SCHIP. And some of this room now fortunate enough to participate in those plans. But again, it's about if people are concerned about the debt, went from 1789 through 2001, this nation went $5 trillion in debt. In the following 8 years, we doubled it. And if you're concerned about the debt, there's no way to ever have a balanced budget again until we get healthcare costs under control and contained in this country. So those are some of the things that we've got to deal with, and why we've got to deal with them. All this is helpful to me. I can assure you that, and I'm impressed with how many people out stoplighted me.
That won't happen again. I can tell you that.
But I can tell you that I'm going to make sure that I was a I promise you that I'm going to keep rural health.
Hey folks, this is Mike McEntee. We are watching from the White House right now. The president is supposed to be giving an address here on tax reform, and we've just been given the 2-minute warning, so that should be starting here momentarily.